Hi, everyone. I'm Dr. Suritha Rao. I'm an associate professor at the University of Connecticut Health Center in the Department of Psychiatry. I'm an addiction psychiatrist, and I'm also the residency training director for the psychiatry residency program. And today I will be talking to all of you a little bit as an overview about pharmacotherapies used in opioid use disorders or opioid addiction. So this is just a picture of a poppy field. Sometimes when patients meet me and talk to me about marijuana, saying it's natural, it's a leaf, I say to them, everything is natural and a leaf pretty much that we abuse as our major substances. You know, morphine comes from the poppy plant, cocaine comes from cocoa leaves, tobacco, and so on. So a little bit about the neurobiology of opiates. So there are several different opioid receptors, but the main opioid receptor that is important for both pain relief, analgesia, and also for the euphoria that people feel when they use opiates, and for the addictive properties is really the mu opioid receptor. And so that's responsible for all these three effects. It's also responsible for tolerance and withdrawal. So tolerance is when you need more and more of a drug in order to get the same effect, because your receptors get used to that amount. And withdrawal is the opposite of tolerance, where if you stop using the drug after using it every day for a period of time in increasing amounts or in the same amount, that now your body goes through these characteristic symptoms, which can be very unpleasant as your receptors get used to not having any of this opioid. And then the next neurotransmitter on there is dopamine, which is implicated in all types of addiction, no matter what the primary neurotransmitter is, because dopamine is the reward and reinforcement neurotransmitter of the brain. It has several pathways, but the mesolimbic pathway, which is a very phylogenetically old pathway and drive behaviors like food and sex, that is hijacked in addictions, making the brain believe that the addictive drug is more important than survival of the next generation. And so all drugs of abuse have effects on the dopaminergic system. That is what explains why people go back to something after they have been detoxified and some time has gone by. So the next slide is just statistics. I'll let you read it in your own time. It just shows the dramatic increase in overdose deaths in the United States. This one shows from 2000 to 2015, from any opioids, from heroin, from synthetic opioids, and commonly prescribed opioids. So a little bit about fentanyl. Fentanyl is a very powerful synthetic opioid analgesic. It is 50 to 100 times more potent than morphine, and it is typically used to manage people after surgery for pain relief and also for severe pain, or sometimes end-stage cancer patients. In fact, just earlier today, I saw a very young woman who has end-stage cancer who is taking fentanyl. And up until recently, fentanyl was only abused by physicians, and that too typically by anesthesiologists, because nobody else had any access to fentanyl. But now, for the last few years, fentanyl is being manufactured mostly overseas and is being sent over and distributed on the street, and people are using it either mixed with other oral opiates or crushed into some other kind of tablet or mixed with heroin, and they're dying because it is such a strong opiate. So we talked about withdrawal symptoms before when we talked about tolerance. So what does opiate withdrawal look like? Most people addicted to opiates are just terrified of opiate withdrawal, and a lot of their behaviors are driven by this fear of withdrawal. Opiate withdrawal typically doesn't kill anyone, so unless you're very infirm, old, or have a lot of medical conditions, you are not going to die from coming off opiates. So unlike alcohol or benzodiazepines or barbiturates, where the withdrawal is life-threatening, here it is not life-threatening. But the person feels like they're dying. So it's like having the upper respiratory flu and the stomach flu together, combined with severe cravings, insomnia, anxiety, and mood swings. So you basically have a runny nose, tears are running down from your eyes, you have muscle aches and pains, chills, goosebumps, severe abdominal cramps, diarrhea, vomiting, nausea, and along with this, the insomnia, severe anxiety, intense cravings. And depending on how long-acting the opiate that you were using was, if it's a short-acting opiate, this usually resolves within 7 days. If it's a long-acting opiate like methadone, it can last 14 days. So what is the treatment for opiate withdrawal? There are two ways to treat opiate withdrawal. One is to replace the opiate that was being used with either methadone or buprenorphine, and then taper it down. So the short taper can be done very easily. People can be taken off any amount of opiates that they're using in 5 days. So you can start methadone at 25 to 30 milligrams. That's where the real detox starts. And you can reduce it by 5 milligrams each day. Buprenorphine, you can start with 4 or 8 milligrams and again reduce by 2 to 3 milligrams every day until they're done. So you can do this very short 5-day detoxification. No harm will come to the patient. A longer taper is often done outpatient, 6 months, 1 year, typically in methadone maintenance programs or outpatient offices that are doing buprenorphine maintenance. There's no real advantage to a longer taper. Some people believe that a longer taper allows the patient to more successfully come off opioids. So in my own clinical experience, that has never really happened. If people are having that much difficulty getting off their opioid agonist medication, whether it's methadone or buprenorphine, maybe they should seriously consider going on maintenance medications and just stay on these meds for like 2 years or longer and then decide what to do. The other medication that's used is clonidine, which is actually a blood pressure medication. It is a medication that reduces alpha adrenergic activity throughout the body. So it reduces adrenaline, noradrenaline activity, or epinephrine, norepinephrine activity, and therefore it helps the patient to feel better. It does not pack the punch of getting a detoxification using methadone or buprenorphine. So if clonidine is being used, the patient really should be given some benzodiazepines like clonazepam or lorazepam just to help with the insomnia and anxiety. In both of these tapers, they're often given a lot of other medications to help with the diarrhea, the stomach cramps, the chills and body aches. So there's a lot of as-needed medications added. Psychosocial treatments are crucial at every stage of addiction treatment. So even with all of our medications that we have, which are not that many, they only form about 10 to max 25% of treatment effectiveness even after the detoxification period. A lot of getting into recovery from any kind of addiction is about psychosocial treatment. So group therapy, individual therapy, family work, relapse prevention therapy, which is one of the mainstays of addiction treatment, which is cognitive behavioral therapy specifically developed for addictions. Engagement in 12-step programs like Narcotics Anonymous, Alcoholics Anonymous, and then learning healthy coping skills, relaxation techniques like meditation, art therapy, cooking, connecting with friends, just other things to help change your mood rather than a chemical. So these are the main medications being used for the treatment of opioid use disorders. These are the maintenance medications. So naltrexone is a blocking agent for opioids. It is not addictive in any way. It is the longer-acting version of naloxone. You might have heard a lot about naloxone on the media, which is given to patients when they come to emergency rooms to reverse an overdose from opioids, and now it's being freely distributed to patients and their families, also used by emergency medical technicians out in the field. So naloxone is very short-acting. A patient often has to receive several doses to successfully prevent overdose, but its longer-acting cousin is naltrexone. So patients often get naltrexone either 50 milligrams daily, or they take 100 milligrams on Monday and Wednesday and 150 on Friday. And it's observed by somebody, either their therapist or their wife or somebody at work that's designated to make sure that they take it, their Narcotics Anonymous sponsor, someone just for some accountability. If the patient has no one, then they take it themselves. So if they take the naltrexone and they use an opiate of any sort, prescribed, heroin, something bought on the street, they won't get sick, but they won't feel anything. They can't override the block. They would stop breathing and die before they felt any high or euphoria or pain relief. These patients sometimes have to wear a special bracelet because in case they got into an accident or something and they were brought to the emergency room, they have to tell the doctor that they can't take narcotics because it wouldn't work, in which case they're often given Toradol, which is a Tylenol-like medication, an NSAID, non-steroidal anti-inflammatory drug, and it's given IM or IV for a few days until the naltrexone wears off. Methadone and buprenorphine are the two medications that have a long-established history of being used as agonist maintenance medications. So what does that mean? It means that they occupy the opiate receptors in the brain. They are themselves opiates. Methadone is a full agonist, which means it turns the opiate receptor on all the way. Buprenorphine, also known as Suboxone, which is its trade name from one company, is a partial agonist, so it turns the receptor on halfway. So it's like attaching to a light socket and either being a 100-watt bulb or being a 50-watt bulb. Either way, both of these medications help to treat, they prevent withdrawal, they treat the drug hunger, which is very important. Drug hunger is actually a real term that we use in the addictions world, which patients can describe to you what it is, this desperate desire to use. And it helps to keep the patient stable while they work on other aspects of their life. Once they've gotten to a certain maintenance dose of methadone or buprenorphine, then they are no longer sedated or feeling any kind of high from it. It just sort of keeps them level, and they're long-acting medications, so they last 48, 72 hours. But they're taken every day. In the United States, most of the buprenorphine that's utilized is mixed with naloxone, which is the agent used to reverse opiate overdose. And this is done so that if the patient crushes and injects the film or liquefies the film and injects it, that activates the naloxone, and now they will go into withdrawal. This is just done to prevent abuse. Normally, it's taken sublingually under the tongue, and so that mechanism does not activate the naloxone. So one thing to remember, which is controversial among the lay public, and maybe even a little bit controversial among healthcare providers, physicians and nurses, but not controversial among physicians specializing in addictions, is that for opioid use disorders, for opiate addiction in particular, relapse rates following detoxification are high, no matter what kind of treatment the patient does. And so oftentimes people will return to their opiate with all of the risks of contracting, especially if they're using needles, contracting HIV, Hep C, dying from overdoses, and all of the other psychosocial consequences of leading an actively using drug-using lifestyle. So all of the research from the 1970s on has really shown that the most effective treatment for long-term stabilization of patients with opioid use disorders is agonist maintenance medication, so methadone or buprenorphine. But still, a lot of families, have a lot of mixed feelings about it. They want their, loved one to just go on something for like a few days and come off, or go on something for a year and come off, but then they might be very angry with them when they finally relapse. So we went over some of this. This is all about buprenorphine. Overdosing from buprenorphine is very, very difficult. It's almost impossible because the respiratory depression that comes from opiates, being that it's a partial agonist, it goes up to a certain point and then it kind of levels off. So your respiration is depressed, and then it kind of levels off. But if it's a full opiate agonist like methadone or heroin or OxyContin, then the respiratory depression just goes on until you stop breathing and die. But caution still must be used because if the pure form of buprenorphine without naloxone is injected along with benzodiazepines like alprazolam, lorazepam, diazepam, the patient can die. And there have been deaths in France, several deaths where patients have injected these two drugs together and died from them. Pregnant women, pregnant mothers with opioid use disorders are maintained on either methadone or buprenorphine, and they are typically only given the formulation that contains pure buprenorphine, and this is because opiate withdrawal can trigger miscarriage in a pregnant mother. And so if there's a pregnant mother, we try never to send them to detoxification, even if they want to. We stabilize them on either methadone or buprenorphine, and we tell them that after the baby's born, they can taper off if they want. And so they're given the pure form of buprenorphine because if they are tempted to inject it, this way they at least don't go into opiate withdrawal and there's no risk of miscarriage. Naltrexone, we discussed already, binds tightly to the receptors, turns them completely off, because it will even prevent the patient's natural endorphins from attaching to their opiate receptors. It can cause some dysphoria. So if the patient's already a little depressed or anxious, you just have to be cautious about it. There's also a long-acting form of naltrexone, which is injectable once a month. So it's a really good intervention where instead of the family watching the person take the naltrexone 3 times a week, they just watch them getting injected with it once a month, and then the patient basically can't use any opiates for the month. But it's extremely expensive, several $100s. I'm not sure exactly how much, but somewhere between $700 and $900, something like that. And a lot of insurances won't cover it, so that's become a barrier. Naltrexone is also used as a medication for alcohol use disorder. If you drink on naltrexone, nothing bad's going to happen, but it just reduces the reward and reinforcement from the alcohol. We went over methadone. It's a very long-acting opiate. Once the patient has been on methadone maintenance therapy and they've gotten to a higher dose, they develop what's known as cross tolerance. So I'm doing the little, the little inverted commas because methadone is an opiate. So when we say they develop cross tolerance and it acts as a quote-unquote blocker, it's not really a blocker like naltrexone. But when they get to a high enough dose, their receptors are completely occupied with the methadone, and a shorter acting opiate like heroin, if they use it, won't have any effect because it won't be able to get onto the receptors. And if a patient is being switched from methadone to buprenorphine, they have to be off the methadone for at least a week to 2 weeks and be in real withdrawal. Otherwise, the buprenorphine will trigger off opiate withdrawal, which is not easily reversed. So this is just a summary. There's a tremendous amount of research on the pharmacological treatments of opioid disorders. It's gone on for the last 50 years with both what are known as opioid substitution medications, or in medicine we call them agonist maintenance medications, meaning that they are full agonists or partial agonists at the opiate receptors. Patients are maintained on them. They get the opiate effect without being high and can stabilize their lives. And antagonists like naltrexone. And there's a lot of public health benefits to placing the patients on long-term agonist maintenance medications, which physicians of all sorts, physicians specializing in addictions, were concerned about the public health impact as well. So overdose deaths, which affect the patient as well as the family, and then the whole risks of sharing needles if they become injection drug users. So HIV, Hep C, spreading of those illnesses, and for women patients, exchanging sex for drugs, getting traumatized that way, and then committing crimes, the loss of jobs, effects on their families, all of those things. And when people go to methadone maintenance, it's highly regulated by the federal government. They usually go to a treatment program where they have a substance abuse counselor, they have group therapies, they're getting drug screening. Buprenorphine is sort of similar, but in a physician's office and a little less, structured. But they get a lot of psychosocial treatments, and this helps them to develop healthier coping mechanisms. It helps to move them away from their using buddies, quote unquote, which are these social networks where they were always hanging out with these people that use other drugs as well, cocaine cocaine, marijuana, alcohol, and so they stop using some of those things as well. And it reduces the whole infectious disease issue. So that concludes my lecture. I hope you enjoyed it, and if you have any questions, you can always read more about this on your own. Thank you.